So welcome back to ChatCAST with Tom, Waldron and I. How are you doing today, Tom?
I'm doing good, thanks, Rach. I was just telling you, I've been to the gym this morning with my dad and taught some Pilates, and I'm feeling good this morning, so ready for our chat. How are you doing?
Good, yeah, I'm great as well. And yeah, feeling really good in my perimenopausal state. So, which brings us on to today's topic. So we're going to keep it relatively broad, I think, and we're going to title this Female Health and Performance so that Tom and I can discuss a very, excuse the pun, hot topic right now, but certainly from our perspectives when training females. So whether you're coaching them in a Pilates class, whether they have come for weight loss, whether they've got symptoms, and then maybe talk around, I think, the biggest difference training a female versus if you were training a male. So what's the difference?
Mm.
Why would you train
Mm.
differently, or what other considerations? I think, which the primary thing is hormones, isn't it? Really, Tom?
Yeah, hormones, and I suppose what's also driven by hormones is anatomical presentations and how that can differ in levers or angles or center of gravity, really, and how that informs rehab choices or just how they might perform in sport.
Yeah, great. And I think when I was thinking about this talk, you might think, oh, Rach is an expert at being a woman. I've been a woman all my life. I've been female for 56 years. However, I'm not. I'm only an expert in being me. And so that doesn't
Mm.
make me an expert in what other women feel. So my journey exploring female health, hormones, what the different symptoms and things that other women can go through has been enlightening. I've only got a biased view of what I've gone through. So one single female isn't necessarily an expert at being female. So I think just to bring that to the table first of all. However, I've experienced female hormone symptoms for over 42 years. So I have anecdotal experience that we can maybe draw on as well. And now being perimenopausal and using hormone therapy treatment and being a menopausal athlete. Do I call myself an athlete? I
I
guess
never even heard that before, actually. I suppose, would you call would that is that a term that's
I think
used?
so, because in my head, an athlete is somebody who is regularly participating in an activity and is quite confident at that. So it doesn't necessarily mean you're competitive. I've run
Mm.
regularly, I've run in races,
Mm.
I lift weights regularly, I do classes. So it depends on how you define athlete, but I feel that
Mhm.
compared to other women, I'm certainly in the athletic sort of ability side and
I would say so.
on that. So,
I think compared to all humans on the planet, certainly are.
so it's a nice thought, but I think it is contextualizing that. So I guess then first question, Tom.
Yeah.
I'm aware you are in your family surrounded by sisters and a mother. So do you feel like you've had quite a bit of experience in being around women and what happens, or is it all quite hush hush in your house?
Yeah, that's a really good question, actually. To be honest, no. I'm really close with my mum and I'm really close to my sisters. And my sister, my older sister, was a professional ballet dancer. She's 10 years older than me. And then my middle sister, who's 6 years older than me, was also to a high level a contemporary dancer. And mum taught dance for years and teaches Pilates now. So we're all, and my sisters too, they teach yoga, Pilates. So we've been a really physically active family. But to be honest, it's not been an open conversation, and it's nothing that it's funny, isn't it? When you get older, you almost assume that the way you were brought up is normal, and then obviously you talk to your friends or you talk to other families, and you realize that there were conversations had or weren't had that you had or didn't have, and you start to compare a little bit. So it's a good question, actually. So simple answer is no. I wasn't. I mean, that was never a conversation in the family, but that's kind of what led to probably a bit of frustration later when I became a Pilates teacher, because I work I actually do get a lot of men doing Pilates, I think, probably compared to the average teacher, but I mainly work with women. About 75% of my client base and 90% of my student base, education wise, is women. So it just became quite apparent as time went on that there were massive gaps in my knowledge base that would have been really relevant into certain periods of my career with female clients. And so that's when I would then do like my pre and postnatal training, or I went on, did workshops on women's health. I think even at the Movement conference back in 2016 that you hosted, Rach, in Loughborough University, I think it was Mary. That was one of the first times I was exposed to someone talking about uh, female specific needs in rehab and sporting scenarios. So that was really interesting because I, as a man, wanted to know more about female anatomy. And there's a kind of a social thing that can be almost awkward initially to get over, because on one level I think it's really good that I want to know that stuff, but it's almost like another dimension to be aware of if I am working with a female one-to-one, what's appropriate to ask, what's not appropriate to ask based on so many factors. So to be honest, I think my knowledge base, which is always increasing, is based on the courses I've done later on in life, and then also getting to a point with clients where they feel and I feel comfortable enough to ask certain questions that might be personal initially, if that makes sense.
It does, and it brings to mind the first thing that I hit upon, which is sort of the history of, if you go back hundreds of years, where women go through periods or menopause, menopausal women were burnt at the stake. Historically, they were classed as insane because of the types of symptoms they were going through. Well, we didn't live as long back then either. So I think it's a really pertinent thing to be conscious of, whether you're a male or a female. Training is the stigma that may be in their household or in their environment around talking about female type symptoms, either with a man and or another female. So where in a household it's not talked about, they may feel awkward, as you say, uncomfortable. How can we upskill in soft skills, communication skills, to better understand, and then obviously the physiology of being a female, the anatomy of being a female, or training a female, to better serve those demographics. So I think it's a pertinent start point, is the stigma. It's being lifted, but actually we need to get educated in how we deal with the history of the stigma around it as well.
I think too, as a man, and I'm sure this is probably relatable to female trainers who are working with female clients, but I think for me it came purely down to performance based. Like I just wanted to know more about how to better serve my clients. Yeah. And I think if you've got that specific goal in mind, I think then it can take away some of the stigma a little bit. Not to go off topic, but this is, I think last year at the Kaizen project, Helen from I Move by Care, I think the company is.
Yeah.
She recommended to me the book Unwell Women, which I've started to read. I bought it for my partner last year, and she loved it. Have you read or heard of that book, Rachel?
No, but I'm going to write that down actually.
It's the history. It's brilliant. Unwell Women. It's the history of essentially the medical history of women. So where a lot of these essentially terms can come from. I forget them off the top of my head now, but just basically normal clinical hormonal presentations in women, which back in the day weren't understood. And so culturally, that changed how women were perceived when they were going through certain phases of their life. And even now, obviously, those cultural echoes are still there. But it's a brilliant book. It was really, I'm finding it really enlightening at the moment.
Yeah, I'll definitely check that one out. I guess this is where we come to, is maybe the word's getting out, and there are women out there who are thinking, actually, is there something I can do? What can I do? And I know that there's research that shows 70% of personal training clients are female. I think the fastest growing personal training demographic, 45% are over 55. And perimenopausal women actually exercise far more often than women in their 20s. So this then brings about what solutions are there and what differences should they apply into the cardio training, their gym-based training, they're coming to Pilates. What can we equip ourselves with? So, so I guess, shall we dive into the first thing that you brought up, which was anatomical differences? So what are the ones that you would come to mind that you would share with anybody listening?
Yeah, typically a clear anatomical difference in male to female would be the pelvic girdle. So the pelvis being the middle of the body, so it's essentially the center, it's the junction from the lower and upper extremities. And yeah, so the pelvis is 4 bones, 10 joints in total. And in the male, typically the pelvic girdle will be a bit more narrow and a little bit higher up. Whereas in the female, it's normally a bit lower down, and then it's a bit wider in its diameter. So there's childbearing reasons for that in terms of having essentially more space, so having a bigger pelvic inlet and outlet. But then that does inform functional differences. So one of them being the forces that can be exerted on the lower extremities. So an area that is typically spoken about with regards to anatomical differences in male and female is the Q angle. So the Q angle, if for people who aren't familiar with that term, so it's essentially the force on the knee from the quadriceps, and it's informed by the pelvis as well and ground reaction force. So you have the hip bone, the ASIS, anterior superior iliac spine. For people who are listening, those bony protrusions that you can feel at the end of your pelvis towards the front, that's your ASIS. So you typically draw an imaginary line that would go towards the knee from the hip bone to the knee bone, and that would be one line. And then to get the Q angle, you would go from the tibial tuberosity, which is where the patellar tendon goes from the patella to the tibia. And then you would draw a line, and the theory is it would go through the center of the patella. And then whatever that angle is your Q angle. So because the geometry can be different in the male and female, one of the theories, depending on, again, culturally, depends on what part of the world you come from, but females will have a bigger Q angle. So they have more forces going through the knee, which may predispose them to certain knee issues, such as patellofemoral discomfort, pain, potentially cartilage issues. And I think I read a stat once. I think women are twice as likely, maybe more than twice as likely to get ACL issues in sports than men. And a lot of these factors can be based on, again, the structure of the pelvis and lower limb. So I think that's really relevant. I think there's, especially since women's football has become more popular in the last, I guess, 8 years or so, which is brilliant. But what's been really good as a side note is there's now more data on the injuries that might be higher likelihood in the female category of sport than the male. So I know the knee and how the knee receives ground reaction force when they land from a jump in football, for example. That's spoken about a lot more. Does that make sense, Rach?
Does. And what goes along with that, what's coming to mind for me, particularly in females, is not only have they got that increased Q angle, around the female cycle, they will have more laxity in connective tissue due to the way the body prepares for getting pregnant and having a baby. So in terms of the athlete, as you mentioned, the football players who've got that excessive Q angle, they're landing, they're cutting, changing direction. They may have that extra laxity around the joint, the excessive angle, the hips are widening. That's going to increase the risk, isn't it?
Absolutely, yeah, 100%. And I think, it's kind of a perfect storm in a way. Like, I suppose, as you were just saying, which is good, more women now are doing, let's say, more strength training. I know from anecdotally in the gym, there's just more women in the gym, and they have more, I guess, functional clothing, like good elastin in the leggings or in the shorts, so they can do deep, heavy squats. And even in my lifetime, I guess like 15 years ago, there were just less women in the gym. So it seems culturally, strength training is more accepted now for women, which is really good. I guess not even from an athletic point of view, but almost like leisurely. Like if you enjoy going to the gym, that's a normal thing for women to do. However, I guess before, so let's say strength training wasn't so much on the likelihood of what you might do in the gym if you're a female, lifting weights, and then you're dealing with this increased laxity in the connective tissues, then that's kind of a perfect storm for increasing the likelihood of injury, because we know that strength training is very good for improving proprioception. We know connective tissues are typically loaded with proprioceptors That's good for coordination of the lower limbs when they're landing from a jump or if they're maneuvering around a pitch in football. But also it's strengthening and toughening up the collagen, which is usually is in the extracellular matrix of connective tissue. So I think it's really good now that it's more accepted that you can get strong in the gym without necessarily having to look really bulky, which I know for a lot of females can be, aesthetically why they don't want to do that all the time. So yeah, I think like in terms of when does it start to become meaningful, like what might you do differently? I used to work with a lot of when I lived in North Devon in the country, I used to work with a lot of female volleyball players and like really good beach volleyball players. And so a lot of that was looking at landing and looking at lower limb alignment when they're landing, if we can give them different options when they're landing. But also the areas that are typically going to be more loaded as they land, which if you've got a typical wider female pelvis, the inside of the knee and the front of the knee might be more loaded. So strengthening those quadriceps and those adductor muscles can be really beneficial for reducing the risk of injury.
Yeah, yeah, it was interesting. I was just thinking back to, I think the first time I went in the gym was 40 years ago. I was about 16. Women not wanting to get bulky, and I've spent 40 years trying to put some meat on.
Yeah, I know.
But yeah, so you talk about there can be very bespoke training to reduce that risk, specific to a female anatomical presentation. And what's your understanding of, are you familiar with the understanding of how you might cycle their training of plyometrics, for example, around their cycle? Because if they're a team player and every third week they're in that time in their cycle when they have more laxity around the joints, is that something did you at that point ask them about the cycle and then back off from plyometrics or something, or was that not a conscious thing at that point?
It wasn't conscious at the time at all. And I think it wasn't conscious on their part either. So I think the education has definitely come from both ends. So my education has been sometimes doing the wrong thing and then actually the client knowing better and then giving me some feedback, which is invaluable as a younger guy. And then also, or just neither of us really know, we're going to keep training and there may have been some injuries along the way or some minor injuries along the way. But like you say, understanding the cycle that happens monthly and how that can impact, obviously, alignment in terms of joint laxity, but even just their sensation as they are increasing load in the body as well. So their pain sensitivity, especially in the early stages of the menstrual cycle, can be heightened in certain regions of the body. So I think that's become very relevant. So now when I've worked with athletes and working more with dancers, so ballet dancers, is doing less jumping in those early phases and actually doing more slow eccentric training. And what you might, I guess, perceive as almost like alignment training, where it's just reevaluating alignment and then just loading the body in certain alignments. And then when we get back towards the end phase, where we're kind of out of that cycle, back into the plyometrics, back into more ground reaction force exercises. How's that been for you, Rachel? I know that you obviously are very active in the gym. I know that you've worked with female athletes and you do Olympic powerlifting. So how has that been with you? Has it changed your training over time, knowing more about the female physiology?
Only more recently, so not when I was in pre-menopause. So when I was in the female cycle, what I did know was I felt better in those first 2 weeks when I'm bloated, when I'm in that follicular phase of the cycle. Endurance running, I felt good. It made me feel better. Even though I've got a sore belly, the endurance side was great. The second half felt different, and that was probably when I would load and strength train the luteal phase. And looking into the physiology of it now makes sense. But this isn't really widely spoken about. You just run every week or you strength train every week. But actually, there are modifications we can make based on that. So now being perimenopausal and studying the effects of the withdrawal of certain hormones, the reduction in estrogen, progesterone, and how that's influencing me physically, I went to very severe vasodilation symptoms, vaso symptoms, so lack of sleep, hot flashes, anxiety and depression. That really wasn't
Really?
typical of me. And I think it was when I was getting those type of symptoms, I thought this isn't right. Kind of crept up. That's where I did my research into how to use exercise to physiologically help through that. And also, I actually did go down the hormone therapy treatment route because the symptoms were quite severe, and it immediately alleviated the symptoms. So now my training is very conscious around sprint intervals, high intensity interval training. There are heavy loading, so very heavy. So I've always been a sort of 8, 10, 12, 15 repage in the gym. So I'm now sort of trying to get into the 5, 6 reps, so much heavier, to give my body a physiological response that will then help with perimenopausal symptoms. So I know I'm jumping between the two because we've got to notice the difference between premenopause, so just basic menstrual symptoms, and then menopausal type symptoms, because it's different.
Can I ask, because I think it might be interesting for people listening, is when you had the treatment, was it a fast shift in your symptoms, or did it take? I know you said it was quick, but
within 10 days. So the decline, or the gradual onset of symptoms, was that brain fog. It was that, am I going mad? I didn't want to train. I didn't want to get out of bed. I couldn't be bothered to do my hair, my makeup, just in a tracksuit. No motivation, actually feeling like, what's the point in life? I mean, I wasn't suicidal, but it was really odd. Couldn't sleep. I normally sleep like a baby. Even feelings of anxiety, hot flashes that just drove woke me up all the time, literally drenched in sweat. So I did start doing research. I watched some documentaries, and I'm going back 6, 7 years now, and went to speak to the doctor, who said, are you exercising? What's your diet like? I was like, well, I would, but I haven't got any mojo. So I went away, started to try exercising, eventually went back again. I was exercising, wasn't changing anything. And I chose to, they asked me what I wanted to do. I said, I'd like to go on hormone therapy treatment, please. And within 10 days, it was like, Rachel, I forgot how good I normally feel. So it would obviously be in a gradual decline. I think this is an important part of what you were saying, is understanding how to communicate. And obviously, we don't want to be saying to a client, oh, are you going through the menopause? But actually, are there subtle ways we can use motivation interviewing to help them maybe get to that conclusion themselves? But yeah, it's been I'm still in the journey, by the way. I'm still exploring different ways of training, but yeah, it's definitely making a difference.
I just think you should talk more about that if you want to in your blogs. It's fascinating. It is really fascinating, actually. But again, as a male, like, I'm sure for women it's even more interesting because it's relatable. But like, this is, you don't know what you don't know, right? Like, I'm still learning what every day you reset, don't you? You're always different every single day, pretty much. And especially if you're going through these pretty drastic hormonal changes. I just think, it's not the PT's fault that they may not know that in the gym when you come for pull day, but I just think it's so relevant, isn't it? Like, and I was thinking too, just when you were talking about the positive changes in the treatment, I was just thinking, isn't it cool that we live in a time where we can actually have like medical intervention and it's actually effective?
Yeah, and it's not right for everyone. So to go with that, anybody listening, I'm not saying we should all go on hormone therapy treatment. I think it's a very specific demographic, because it can be done with exercise and nutrition. So, but for me, for my symptoms and my quality of life, I made that choice, but I made an educated choice. But just to bring to light another conversation I'd like to have with you, Tom, is I have not had some of the more severe symptoms that other women might have, like pelvic floor issues, leakage, sort of vaginal dryness type stuff, and prolapses, and much more maybe embarrassing things. That wasn't part of my symptom package, if you like. So that side of it, which I would imagine as a female would be harder for someone to talk about, but may make them uncomfortable sitting on a bike or doing
Yeah.
certain jumping exercises in these very popular HIIT classes because they're
Mm.
nervous about leakage or, you know, something horrendous happening. What's your thoughts on, if I broaden it a little bit, on pelvic floor strength and
Yeah.
the way we as coaches, trainers, Pilates teachers deal with that in terms of female clients?
Yeah. This is something I'm really passionate about because I was when I became a biomechanics coach and I started to assess all my clients, and again I'm working mainly with female clients. So I started doing this over 10 years ago. So one thing I would do is, you know, I'm working with these female clients. Some of them are athletes, some of them are just people want to get stronger, fitter, and we never spoke about the pelvic floor. It just wasn't even on my radar, and they weren't talking to me about it. I'm like a 24-year-old kid, so I guess I'm not the demographic that someone's going to come to for their incontinence issues. But so what would be really fascinating is I'd be working with someone's biomechanics, looking at their foresign, I'm looking at their gelées, feet profile, and then we're doing Pilates. We're getting more mobile and stronger. And what was really interesting is I got quite a few times over the course of maybe, let's say, a year, quite a few female clients saying, so I didn't come in for this, but my incontinence issues have gone away or they've dramatically decreased. And we're not talking pelvic floor. I'm not doing pelvic floor cueing, but they were saying that they felt like what I was doing with them in the movement classes was a massive factor in how their pelvic floor function had improved. So for me, this was like it was a real like spark to I want to know more about the pelvic floor. And so that led on to like years of studying the pelvic diaphragm. So I suppose one thing to answer your question properly. So yeah, females as they get into the into their later life, it can be before menopause, could be later on. They can reduce estrogen levels, and that can affect the strength and the elasticity of the pelvic floor. So so yeah, the pelvic floor is a series of muscles. There's actually a lot of skeletal muscle tissue, which is good because that means we can actually strengthen it in the same way we would strengthen a bicep muscle or quad muscle. It's also a massive series of connective tissue. So a lot of that elasticity comes from connective tissues like the endopelvic fascia. You've got perineal fascias everywhere. So it's a really dynamic area. And again, because it's at the pelvis, it's in the middle of the body, it does have a function in how forces are mediated from the upper and lower extremities. So as you were saying, Rich, yeah, a lot of people can have incontinence as they get older, or even early on, they can have incontinence. Normally urinary incontinence. So people who don't know what that is, it's incontinence of the bladder, really. So the urethra, you're not able to keep in the urine. So I guess culturally, we always talk about, oh, it's not strong enough. And there's definitely people where they need to strengthen their pelvic floor. That it's a bit too flaccid, as we were saying, it can lose its strength or its tone. But it's equally can be from the pelvic floor being excessively tight. So being hypertonic. So that's when it's not able to relax or it's lost that elasticity. And then the third one is it can also be a coordination problem. So when you cough or jump, run, stand up or squat, and you're increasing intra-abdominal pressure, what you obviously want to have happen is as intra-abdominal pressure increases, the pelvic floor tone also increases. And sometimes we don't know why, it just is delayed. So it's not that it's not strong enough, it's just not using that strength at the right time. And so it's a delayed activation. And that might be postpartum. If there's like an injury there, it could just mess with the proprioception. It might be a sedentary issue. There's not really like, can't point to one reason, but we know that can be a factor as well. So I think one thing is knowing, well, how do you know if it's delayed, weak, or tight? The weak or tight one is tricky because the symptoms are pretty much exactly the same. So when I work with pelvic floor stuff, we do some strength and conditioning, which might be some pre-activation, the classic cueing. But my personal preference is actually strengthening muscles that we know connect into the pelvic floor, like the glute max, the adductor magnus, managing intra-abdominal pressure in a way that's complementary. But a delayed pelvic floor, that one's a bit more tricky. So a little, just for people listening at home, a little way of finding out if you've got potentially a delayed pelvic floor is, so if you know that you're experiencing leakage when you cough, So you cough and then you experience, let's say, a little bit of leakage. That could be, again, a tightness issue, a weakness issue, or it could be a delayed issue. So if you pre-activate a little bit before you cough, and then that actually maintains um, the urine, so you don't have that flow outward of the urogenital region. That can be a sign that it's delayed, because and especially if you only engage a little bit. So we're talking like I'm talking like 5%, like low level activation. And something as simple as just doing a bit of pre-activation before you cough, or if you know you're going to sneeze or cough, doing that for like a few weeks, that can be enough to remind the brain, oh, I just need to make sure those muscles are on when I cough, and then it kind of resets again. So that can be a really simple solution. So I think so for a lot of women, and I know this could be the same in the core world and lower back pain world, is we know that these cues can be beneficial, the pre-engaging the pelvic floor. One of the things that I see a lot is women pre-engaging, and then the education around that has been not good. And then they think that's what they have to do all the time. So they're always gripping their pelvic floor. And there's actually some research to show that athletes that have the strongest pelvic floor have the highest levels of incontinence. So it's not necessarily a strength deficiency. And so that's when it's a little bit more education around you can actually let the pelvic floor go, quote unquote. And then if we've got good pelvic movement, so you can move the pelvis, we can load the pelvis, that can engage the pelvic floor at the right time. And then that's another way of improving pelvic floor support of the pelvic organs. So it's a really, like, not to overcomplicate it, but I think the pelvic floor, very similar to like the TA, has been probably like it's been done a disservice in how you just train it. You just think you do a cue and that's it. That's the end of the story. You move on. When really it's this very dynamic area that has many different functions, and you can dynamically train it through so many normal exercises. It's just having the right education around those exercises, if that makes sense, Rach.
It does. I've just been scribbling notes because that I've just learned from you something then. It's about the timing. I don't teach Pilates, but it's from there. I'm not sure that you got that. About that pre-activation. And I remember some time ago, a long time ago, it just reminded me of on our course when we talked about lying supine, basic crook lying, doing the leg lift with one leg bent, one leg straight. So for static abdominal strength in the core isometric ratio testing, if somebody was doming during bracing or any of those, to push the tongue into the roof of the mouth to pre-activate, and I wasn't sure, I didn't really understand it at all back then, and now it's made me think of that when you said by pre-activating before you then load, it almost identifies if it's a coordination thing, because I didn't realize that was a thing. I'd heard about strength and laxity of the pelvic floor, but the actual timing and coordination I didn't really understand, but that kind of makes sense now you've just said that, and a great way to sort of test it.
I think so, yeah, and I should say to the audience here, like I'm not diagnosing pelvic floor issues. I work with a pelvic floor therapist, so if there's anything clinical that pops up, straight away referred, and then they normally come back. However, I think from a training point of view, because we do use these, or people do use these cues, why not just do some little, like we do in the Biomechanics coaching, do some tests, because then you can kind of use your own critical thinking and judge if these cues are beneficial or not. So because I can definitely come across like I'm anti pre-activation, which I'm not really for it all the time. However, there's absolutely a case for it, and there is efficacy for it as well. And in the cases where for a lot of women it can simply be a delayed problem, a bit like how we say, well, the foot could probably supinate, but is it a delayed supination? It's kind of the same idea of it. It's just like kind of falling behind a little bit, because it's part of that classic cylinder, isn't it, of the diaphragm, the TA, the pelvic floor, to help support the spine. So it's been really cool for me, because again, as a male, so learning more about the pelvic floor and being able to actually relate to women about that a bit more. So like you were saying at the start of this episode, Rach, like just because you are a woman doesn't mean you necessarily know about women issues. Certainly as a man doesn't mean I know about women's issues, but being more educated on the anatomy, the biomechanics of that area, the physiology a little bit, then being able to respectfully educate women on things they may not know about their own pelvic floor, because there is obviously some differences in the anatomy, the muscular anatomy in the pelvic floor, male to female. That's been like a really cool professional experience to work with women and have that respectful relationship where they can learn more about their anatomy so they can have a better quality of life. So that's been, yeah, it's been a good couple of years teaching pelvic floor stuff more, and I've been enjoying that.
And I think what's refreshing for a female to be educated by a male is the idea that clearly you've done your research, because you wouldn't know as a man necessarily about female health issues. Me as a female communicating, it's, oh yeah, Rachel's just talking about herself. But actually coming from a male, in some ways, would I have more of a belief in him? Because if a man's talking knowledgeably about female health, I think he's obviously studied it, because he isn't.
Yeah, it's
It
funny.
doesn't make sense.
It does. I've been teaching pelvic floor workshops for maybe 10 years, I guess, actually. And I've not yet had anyone ever have a problem that I'm a male, which I was always a little bit like, oh, am I gonna, like, am I stepping on toes here, or am I gonna, but and maybe the ones that would have a problem would just never come anyway, and that's fine. But it's actually been I think what I've experienced is a bit, I guess, appreciation to even, like you say, to bother to do a bit of reading into it, and then to try and communicate that information in a relatively succinct way. But because also, I mean, we're talking about women today, so not to deviate too much, but obviously men have pelvic floors too, and that's another thing is the amount of men that have said, so have we got a pelvic floor? And it's like, well, what's keeping the organs in? Like, we've obviously got one, and there's actually more similarities than differences. It's more when you get into the anterior part of the pelvic floor. Women just have more muscles basically than we do. There's a bit more going on there with the sphincter control, which is another important part of continence. But yeah, I think that, just to then go back to what you were saying originally, Rach, I think when it comes to, if you are dealing with incontinence, and like you say, it's the jumping, which is obviously the reaction from the floor that can, if the pelvic floor can't deal with that, you can have an issue there. It can also be an endurance thing. So if someone is a runner, and I've had this a lot with runners, is their pelvic floor might be absolutely fine for the first 2 or 3 miles. And it's as they get into that later part of their training, the pelvic floor might fatigue a little bit. And so that's when, rather than just to not run or to only go to 2 miles, then you stop, because then you're obviously plateauing your training. That's when doing interval training can be really beneficial. Simply taking a break can be really beneficial, then you continue. And then also even doing a bit of pre-activation while running, which requires a bit of cognitive coordination to do that, can be really beneficial too. But even on a cross-training level, if someone is a runner and they're experiencing these issues, if they do gym work or Pilates work, we can actually train pelvic floor endurance in those environments too. And then that can have a really nice crossover effect into like a different activity like running or walking. So I think, as you know, everyone's pelvic floor issues are going to be different depending on their presentation, and it's not always straightforward. But I think for a lot of people, in my experience, we should just be training that area like we train the foot or the knee or the shoulder. So it's just having maybe less stigma around that part of the body.
You're just making me think then about one of the gyms that I go to, where you get the young, with all respect to them, young personal trainers doing a HIIT class on the gym floor. And it's more often than not the female demographic, the older female demographic that are in those classes, perimenopausal maybe, that sort of age group. And a lot of the HIIT classes is box jumps, jump jacks, burpees, high knees. And if they're not educated and diplomatic in the way you are in communicating, or communicating in a subtle but respectful way, here's your choice, it can be off-putting. And so this is again where education is so important, even with a young, maybe I don't know, if female clients are on the rise and are the highest population of personal training demographics. And then in Pilates classes, I would imagine a lot of women go because they feel they need a strong core if they've got leakage or a weak pelvic floor. So your insights and your education into the mechanics, even on a simplistic level, what you've described just now, if there's a non-professional female listening to this, that would all make absolute sense. So I think
Yeah.
you do it very, very, very well. And that's, if that can be the way the information is passed on, then that's how young male personal trainers, Pilates teachers can actually respectfully help women of a middle age or higher age group with pelvic floor. But just
It's funny. This is a bit. Oh, sorry,
go
Rach.
for it. Go for it.
I was just to finish with that. Like, this is a bit of a post hoc realization, really. But I think I would say that a lot of people in our industry, you're normally usually quite empathetic. I think so. You like people. You like seeing people achieve. So I do have memories of, like, maybe someone just looked a bit uncomfortable in class, or they didn't come back because of they didn't enjoy something, and I would just go, they didn't like me or whatever it is, don't like Pilates. And then now I'm realizing actually it may have been completely to do with something as simple as having an incontinence issue and simply feeling really embarrassed. So if I just knew a little bit more, not to even approach that person about it, because that they might not want to ever approach me about it, because it's a private matter. However, if I was able to anticipate maybe some needs in a class and then provide exercises or cues or even signpost, I just think that it's just giving people a better experience in the gym, isn't it, or in the studio, which I think we're always trying to do, isn't it? Trying to encourage more people to move and to minimize the excuses.
Yeah, 100%. And I think you're right. It's not about like shouting from the rooftops. I can now train women with weak pelvic floors, form an orderly queue. It's actually the opposite. It's just
Yeah,
it's
yeah,
just drip feeding in alternatives or communication around making it look accessible or feel accessible to those. I'm just mindful of time, but I did want to just touch on one more point before we wrap this up, if I may, Tom. And that's, you mentioned earlier briefly about pain sensitivity. And certainly when I was having full periods going through my teens and up to 45, the discomfort could be horrendous sometimes. And then moving into perimenopausal, it was a different pain. It feels like my whole body's arthritic, like joint pain, muscular pain, just awful. What's your understanding around female sensitivity to pain?
Yeah, I think so. One thing is, so let's say it's time of the month, let's say it's more menstrual related, and there's research to show that pain symptoms in the early phase of someone's menstrual cycle can ramp up, and that may be due to also lack of sleep, which we know can increase pain sensitivity. But also just how the brain is processing the change in the body can also ramp up pain symptoms. And I know when it's postmenopausal, it could be all over the body. I think in more menstrual related, it could be more pelvic girdle, lower back, abdominal pain. My partner suffers a lot of this as well on a monthly basis. And I think, like, it's almost a shame, isn't it? Because then you look at, let's say, young athletes. I used to know a lot of fantastic young swimmers, female swimmers in my school, really, really good athletes. But, they might be seen as lazy a certain time of the month because they are a bit more lethargic, or they don't want to lift as heavy, or they don't want to do that extra lap in the pool compared to the male contemporaries. And I think that's the one of the issues is not interpreting the signals correctly, and that's been a big thing for me. So almost going back to what we talked about originally, so maybe in the first part of someone's, let's say, menstrual cycle, where they may be going through a pain spike, I'm not going to be loading them as much, or we might take longer breaks in the session. Or we might even do a bit more restorative stuff. So actually a bit more mobility, making sure that they're sleeping properly. So asking, how's your sleep been recently? Because we know that lack of sleep can also increase the risk of injury. So I think for me, it's been more the practical stuff with regards to how that's informed my training is. And again, it's an interesting topic, because I'm not just going to ask someone, so are you on your period right now? Because that's not necessarily appropriate. So I think it's also just, I've had it with some clients where they do just tell me, and actually kind of made some notes before, like I kind of have an idea of what time of month they may be on. But I think it's just maybe looking out for some signs, like if they are reporting more discomfort than they would normally do, or if they do just look more tired than they would normally look. just having a bit more empathy with that. But what about you, Rach?
Well, just as you were speaking then, it was making me think around the idea that we have these standard PARQs and consultation forms, and I wonder whether it should be that within them it asks, explaining why, would you like to describe your menstrual cycle? Does it interfere with your exercise program? And so there's a point to it. And then if they would say, right, then my cycle normally runs in this way, and then we can better work with them, because as you've been saying throughout, being respectful. But then is that not the problem, that there's a stigma to that conversation? It's a normal female occurrence. We all pretty much all go through it. You know, we go through it, but we're over in our corner talking amongst ourselves. The boys are
So
like,
true.
you know, so
Yeah, no, yeah. There's a lot of shame, isn't there, around it? It's like it's a shame, isn't it? Like it's silly in a way, because it's like we're all adults. I get it when it's younger kids and stuff, and there might be like family beliefs and whatever. But I think when you get to a point, it's like we just want to know, be transparent, don't you? We're trying to achieve a goal together, whatever that goal is: weight loss, sport performance. You just want to have data, don't you, about how can we best do this for you?
Yeah, and that comes back to my very first point, which is the history of female hormones and the way the stigma still, as you say, echoes through today into the way we talk about it. So it's great that you and I feel comfortable to do this and share this conversation we've had. And then obviously I've got my talk on Friday with SIMSPA. So to be able to bring it to the fore, talk about it, maybe I'll start writing around my personal experiences to share that, and then offer insights, direct them towards you or my website to better understand how to work with female health and performance based on everything we've spoken about.
Yeah, and I think it's really cool because I have a little private community of mainly Pilates teachers. Maybe there's like 300 people in there now, and they've done this private floor program with me. But to give that context, because in this private group, they do actually share about their own experiences, either with clients with confidentiality or of their own experience. And I'm actually often not chiming in. I'm kind of just reading and then listening, and that's been brilliant, because it's just like things I would never think about. And I think it's also quite cathartic for the female teachers to actually have a relatively incognito in place, because these people all over the world, not necessarily ever going to meet, where they can actually share their experience, whether it's pelvic floor related or anything, like whether it's pain symptoms or, so that's also been like a bit of that's been an invaluable resource for me to have at my fingertips, actually.
Yeah. Maybe that's how it has to start, is in these little groups. But
yeah, definitely. Yeah.
Well, thank you, Tom. It's been a really interesting to listen to you. I've learned some stuff. I've been making notes, so I've learned some stuff today. I'm going to go and put into practice. Thank you very much. Any final words, Tom, for our audience?
I would just say, if you're a male personal trainer, therapist, Pilates teacher, and you want to learn more about female anatomy or physiology, I think the best place to start is just to ask questions and just use common sense and social awareness. And if you work with female clients, it's another dimension that might massively upskill your service. So I think just if you're not sure, just start by asking questions.
Yeah. And of course, what you'll see, guys, for those listening or watching this back on demand, is links to get in touch with Tom or myself, where you can ask us anything, and who knows, we may be answering your question on the next Chatcast. Thanks, Tom.
Thanks, Rach. See you soon.